Good morning, everyone in person and remote joining via Zoom webinar. We're going to get started probably in 30 to 60 seconds. The Zoom webinar just takes a little bit to let everyone in, but I'm so glad to see everyone who's joined us in person, and we'll get going in just a minute. Yes, actually, that's a great point, Blair. If you're on Zoom webinar right now and you are at the Psychiatric Institute, you're welcome to click End Zoom webinar and join us in the auditorium. There's plenty of socially distanced seating. Thanks. That's a great announcement, Blair. I'm going to do that every week. Absolutely. It's a wonderful way to show support to our colleagues who are speaking here in person. Okay, I think we're going to get started. So good morning to those again who are here in person and to those who are joining us via Zoom webinar. I'm Jeff Miller. I'm one of the co-directors of Grand Rounds with Kate Elkington and Christine Denny. Welcome to today's Grand Rounds. I have a few announcements before we get started. So the first is about an event next Monday, September 19th, which is a welcome back kickoff reception happening at 4 p.m. here in the auditorium as Dr. Blair Simpson gives remarks here, followed by light refreshments in the Pardis atrium, first floor lobby right outside the auditorium. It is a hybrid event, but we encourage you to attend in person if you're so inclined and able to. And then next week's Grand Rounds, Wednesday, September 21st, will be a fully remote Grand Rounds given by Dr. Carrie Bearden, professor in the departments of psychiatry and biobehavioral sciences and psychology at UCLA. And the title of her talk is Prediction and Prevention for Youth at High Risk for Psychosis. So before I introduce today's speaker, just a few more short announcements. The first is about questions. We really encourage people to ask questions, whether you're here in person or joining us remotely. For the in-person audience, you'll raise your hand and we'll get a microphone to you. For the remote audience, you can post questions in the Q&A function, not in the chat, but in the Q&A function. And if you do so, please let us know if you're willing to be promoted to a panelist briefly to ask your question in person. If that's the case, you can write "can ask question myself" along with your question, or if you'd prefer that we read it, in which case write "prefer to have my question read." It's much more interactive and exciting and interesting for the audience if you ask the question yourself, so I encourage you to consider doing so. And if you do that, you can do it with camera on or camera off, according to your preference. Also, if you post a question, we're trying to prioritize trainee questions, and if you're a trainee, please put the word trainee at the beginning of your question. Okay, I'm really excited to introduce today's speaker, Dr. Joanna Steinglass, one of our own here at Columbia. Dr. Steinglass is a professor of psychiatry and was promoted to that position in July of 2020, so this is also partially a somewhat belated celebration of that promotion. She's also the director of research in the Eating Disorders Clinic at the New York State Psychiatric Institute and CUIMC. She graduated from Amherst College and completed medical school at Harvard, and then residency training here at Columbia and NISP, and then joined the Eating Disorders Research Clinic in 2003. She also serves as the training co-director of the Eating Disorders T32 Research Fellowship. Her research investigates anorexia nervosa through the study of the neural mechanisms of illness and the development of mechanism-based treatments. She conducts interdisciplinary research that uses tools from cognitive and computational neuroscience to apply the latest understanding of the healthy brain to research on anorexia nervosa. She applies these insights to the development of behavioral, neuromodulatory, and pharmacological interventions for eating disorders. And while conducting this highly impactful translational research, Joanna's really also been an outstanding member and citizen of our department. She's been a supervisor, a teacher, a mentor to many research trainees, a supervisor to me from our days in residency, and a member of many committees from the Institutional Review Board to task forces, selection committees. She's basically done it all while she's been here. So it's a real thrill to introduce Joanna today. The title of her talk is Bench to Bedside, From Mechanism to Treatment in Anorexia Nervosa. Welcome, Joanna.
Thank you. That was so nice. Thank you, Jeff. So let's see. It's really nice to be here. It's so much fun to do home team talks. And I also noticed that it was exactly 10 years ago, July 2012, when I last gave grand rounds here. So thank you very much, Jeff, Kate, and others who invited me to be here. So what I want to do is tell you what we've been doing the last 10 years, which was a little bit of work. So it's fun to be able to talk about it, and I hope it's fun to hear about it. These are my disclosures. Okay, so to tell you about the work we've been doing, I have to start by making sure that we're all thinking the same way about anorexia nervosa. So the first part of the talk, I will do a little bit of clinical introduction of what this illness is, and try to get us thinking about it hopefully in the same way, and then transition to talking about some of the mechanism work that we've been developing and the progress that we've made, and then at the end, the fun part when we get to start talking about what we've been doing with treatment. So talking about anorexia nervosa actually starts a very long time ago, when the illness was first described in the 1600s and then named in the 1800s. And here you can see it's described as as kind of focusing on the psychological elements of pursuit of thinness and fear of weight gain. What I'm going to talk about today is actually going to orient us a little bit more to the behavioral elements as the central piece. But it's always helpful to remember how long ago this illness started or was noticed, because it's so tempting to think of it. It becomes so much a part of our cultural discussion and so much thinking about what is it about culture that drives these psychological pieces. It's helpful to remember that all of it is there no matter what is going on with the culture, and that brings us back to thinking about the neurobiology. This was a recent paper that when I was preparing this talk a while ago that popped up right at the right moment, describing in the medical, if you're a medical historian type person, describing these eating disorders back in the Byzantine era. So that's just kind of a fun tidbit. Okay, what is it actually? So the definition of anorexia nervosa focuses on maintenance of a low weight. That's a key feature. Fear of weight gain, and undue concern with shape and weight. As far as these criteria are concerned, if you take nothing else away from this, please remember that this fear of weight gain can be inferred from an individual's behavior. So the person does not need to say that they are afraid. They may in fact say, I know I need to gain weight, but their behavior demonstrates that they're not able to do that. And that's now defines the illness. There are these two subtypes. Some individuals restrict only their intake, and others also engage in either loss of control eating or purging in addition. This is rather a timely subject. As many of you may have seen or heard, there's been a lot of increase in the frequency and severity of the presentation of anorexia nervosa and other eating disorders through the COVID pandemic. We've seen it, there's been published reports from all over the world, Boston, Australia, France, lots of emerging data suggesting that there is an increase in hospital admissions and prevalence of illness. And some reason to think that eating disorders may be more affected than other illnesses. Not clear why. I'm not going to actually dig into that, but it just sort of highlights why I'm glad to be here engaging you in this thought. The standard treatments, the mainstay, the necessary first step is renourishment. This can be accomplished for adolescents using the family as a structure to help refeed the teen, or using inpatient, residential, other types of programming to provide a kind of external behavioral milieu that really nudges the person to override the very intense pull of the illness and help them engage in choices that move them towards health. All of the treatments use behavioral techniques and can be quite successful acutely. Medications are not usually that helpful, with the notable exception of olanzapine, which is the only medication to beat placebo for outpatients with anorexia nervosa. This necessary first step is not the entire treatment. There's certainly much work to do after renourishment, but the best practice for how to do that is actually not yet established. So there's lots of different things that seem to be helpful, and no one clear winning treatment for maintenance care. And then the kind of clinical recommendation is generally a year of outpatient treatment after renourishment. So how well do these treatments do? Interestingly, teenagers do pretty well. So about half of adolescents respond within that first dose of family-based treatment. And then if you look a year later, even more seem to be doing better. So the response rates in teens are pretty encouraging. A little bit more sobering in adults, where the relapse rates after weight restoration, after inpatient treatment, are pretty high. And the mortality rate is quite high. So the reports are, the standardized mortality ratio is 6 times expected, and it's worth remembering that that's because you're comparing them to young women. So young women are not supposed to have a high mortality rate, and the fact is that this illness, that's who it's primarily affecting. It also increases with the duration of illness. On the upside, recovery rates do also increase over time. So there are these recent reports that if you extend the follow-up period long enough, the remission rates are higher, which is encouraging. On the other hand, 22 years is a very long time to be ill. So sobering. So I told you that the main problem is low weight, and that the treatment is renourishment, and that the original reports focused on fear of weight gain and other such things. So I need to make sure that I orient everybody to why we focus so much on restriction. And this is perhaps obvious at this point, that the central piece of anorexia nervosa is the limitation of intake, but it wasn't always so obvious. And the initial years of research before my time in anorexia really well established that the central problem is that patients are not eating enough. There's a lot of data about this. I'll give you a couple of illustrations. Some came from observing intake over the course of a day, where Colleen Hannigan demonstrated that the patients with anorexia nervosa were eating fewer calories than their healthy counterparts. And particularly, if you look on the bar on the right there, particularly we're eating fewer percent of calories from fat. This was well documented by Laurel Mayer here with what I would call foundational research, showing that in an objective setting, when you ask patients to come into the lab, which I'm going to talk about more in a minute, and have them have whatever they'd like for lunch, the healthy individuals in the gray bar consume about 800 calories. The patients with anorexia nervosa, when they come in, consume less than half that. Not terribly surprising. But if you look at the weight restored, when they come back to the lab at the end of treatment, after full renourishment, after consuming 4,000 calories a day, they still, in the lab setting, significantly restrict their intake compared to controls. They eat a little more than they did at the beginning, but they, on the inpatient unit, had been eating up to about 1,000 calories a day. So it's really quite restricted, even after full weight restoration. And again, Laurel showed that this was specifically a restriction of calories from fat. This is going to be essentially the theme of everything else I'm going to talk about. So these are just a couple of the studies that illustrate it, but they're very important studies. This was also corroborated by Janet Shevendak, who demonstrated that if you monitor what patients are eating, even after weight restoration, the ones who are limiting their fat intake, limiting their energy density, which is at least partially driven by the fat intake, those are the ones who go on to struggle over the next year. So this is the end of the clinical summary. What I hope you take away is that this maladaptive eating behavior is the core disturbance, that these are patients who are struggling with limiting how much they eat. They continue to struggle with that even after a full round of weight restoration. And it's specifically the limited calories from fat. And this is related to longer-term course. So they're not eating, they need to eat, they can't eat even after weight restoration. This begs the question, why can't patients eat? And this, I will say, was also on my Grand Rounds presentation 10 years ago. Turns out to be a very challenging question and a very complicated problem to try to understand. What is going on in this illness that gets in the way of patients' ability to nourish themselves? So to tackle this very challenging question, about 10 years ago, Tim Walsh, who's the founding director of the Eating Disorders Clinic here, took everything he knew about anorexia nervosa, sat down in his office, put it all together to describe the illness and combine it with emerging information about what we know about behavior from the field of cognitive neuroscience, which was rapidly increasing our understanding of behavior in the brain. And what he described was that the illness often begins in adolescence with dieting. And by dieting, I don't necessarily mean a decision to go on a diet, but some sort of change in intake that occurs for some reason. And that for that individual, for some reason, that change in behavior is rewarding. And we know that it's rewarding because it gets repeated, and that is part of the kind of foundation from the behavioral neuroscience that when behavior gets rewarded, it gets repeated. Now, the rewards can be entirely idiosyncratic. They could be they could be receiving external praise of some kind, could be some internal sense of control, could be anything. But for whatever reason, for that individual, it's rewarding and it gets repeated. And then what we know about behavior that gets repeated is that over time, the reward doesn't matter as much. And it ceases to be, it stops happening because of the expectation of the reward and starts happening behaviorally because of the cue that sets it off. And when that happens, we think of it behaviorally as a habit in these neuroscience terms. And importantly, that is accompanied by a shift in the neural circuitry that governs the behavior. So this became the hypothesis that we've been trying to probe for the last decade to try to understand the mechanisms of illness. First, to make sure that we're onto something with the behavior, we started to look at, is there evidence of habits from the behavioral perspective in patients with anorexia? And to do that, we borrowed from the social sciences using this scale that's called the Self-Report Habit Index, and essentially captures the extent to which a behavior is frequent, repeated, automatic, and has been shown it captures a construct called habit strength. And habit strength is a measure that predicts essentially the recurrence of a behavior even when you didn't necessarily exactly want it to happen. So in the social sciences, it's been used a lot to establish new behaviors like getting people to eat their vegetables or getting people to be more physically active. In the psychiatric world, it's been used to show things like likelihood of having a cigarette even when you're in a certain context, even when you were ostensibly trying to quit smoking. So we took it and we adapted it to think about anorexia nervosa and to look at some domains of behavior that we know are particularly relevant to illness. And these analyses were led by Lauren Davis, who's now a graduate student at Rutgers. And she found that when you ask both healthy controls and patients with anorexia nervosa to identify something that they think is a habit in these 4 different domains: restriction, compensation, delay of eating, and rituals. Those are eating disorder relevant domains. Everybody can come up with something that they think of as a habit. So for example, for restriction, it might be something like I use low-calorie salad dressing. But the extent to the score on habit strength differs between the two. So these are greater habit strength amongst our patients. And that this, if you average the 4 to get a total score, the total score is related to duration of illness, which is at least consistent with the model that Tim laid out, which was that over time these behaviors become increasingly entrenched, and that's why they're so hard to change. So then we started collaborating with Daphna Shohami, who is now the associate director of the Zuckerman Institute, Zuckerman Mind Brain Institute. And she helped us to think about how we could capture this behavior from the cognitive neuroscience angle, focusing on decision making. So one of the problems in restriction is you're talking about the absence of a behavior, and that becomes very hard to study. How do you study what people are not doing? And the kind of reframe that was very valuable for this work was thinking of it more as an issue of choice. It's not that they're not eating, it's that they're choosing particular foods, and these are the low-fat foods. And for that, there was actually a body of literature to work from, because it turns out that the cognitive neuroscientists really like to study food because it's supposed to be always rewarding, and so you can think about how people will make choices, giving them the reward of food. So we took this task. It was adapted from Todd Hare, and with Janet's help, again, we made a whole bunch of different pictures of food. He had been looking at self-control and looking at how people choose between diet foods and junk foods. We wanted to look at how patients would make choices about foods that they actually would encounter or would choose to eat. So we created a whole bunch of pictures, and Janet very carefully figured out how to classify them as either high-fat or low-fat. We've actually published this library in Open Science in the Food Folio at Columbia, so that anybody can get the pictures and can get the full assessment of the nutritional description of the foods for use in your own tasks. And we use these pictures for this food choice task. So here's how the task works in brief. There are 2 blocks of rating scales where every item is rated for healthiness on a scale from unhealthy to healthy, and tastiness on a scale from bad to good. And then the computer snags one food item that was rated as neutral on both healthiness and tastiness, and that becomes the reference item for the choice block. The choice block is the main thing we're going to focus on. The first 2 blocks, though, are necessary because, as I was saying, for the healthy people, you can imagine, you can presume that the food is rewarding. You can't make that assumption when you're working with eating disorders. You can't make any assumptions about how people are making decisions about what to eat. So we needed to have a task that could compare between groups and have some sort of a way to kind of crosswalk between the 2. So the individually rated neutral item is the reference, and then each person is choosing between their own reference item and all the other food items. I'm going to walk you through the results because you're going to see, we use this task a lot, so you're going to see it repeated. So let me make sure that the way of looking at it makes sense. For the healthiness ratings, you can see on the, I always struggle to find the ratings. You can tell, everybody can sort of tell the difference between the low fat and the high fat, where low fat is healthier than high fat. For the tastiness, we were very proud of ourselves that we did a pretty good job matching the low fat and the high fat on tastiness. You may notice that the patients with anorexia nervosa in green basically downgrade their ratings of food in general. But here in the choice block, what you're looking at is the proportion, on the y-axis is the proportion of times that the individual chose the high-fat food or the trial-unique food over the reference food. So on the left is the low-fat bars, and on the right is the high-fat bars. And you can see that there's no difference for the low-fat, but for the high-fat foods, the individuals with anorexia nervosa are significantly less likely to choose the high-fat food. That's what I told you from the beginning. That is not a surprise, but it does show that this task captures what people are actually doing. And now I'm going to introduce you to Janet Shebendak, who is our head of our nutrition lab on the BSU on the 3rd floor here. She runs all these studies where we're able to objectively measure what people are actually eating. And this is one of the ways that eating disorders has an advantage over some other psychiatric illnesses, where there's an actual behavior that we can measure that is the central problem. This is our multi-item meal, which we use to figure out how people actually go about eating. And we showed that the task, what people choose in the task on the x-axis, is related, how much they choose the high-fat food is related to how much they actually eat in the lab. So this is true across lots and lots of people. We have now a task that captures the behavior of interest that's central to the illness. So that allows us now to try to figure out what is the brain doing. And here what we did was we took the task, we did it in the scanner. All of these analyses and these projects were led by Karin Furda, who is now an assistant professor at the University of Amsterdam and is still a very important collaborator. And what you're looking at here is which parts of the brain are active in correlation with choice. So this is a parametric analysis that shows that the ventromedial prefrontal cortex is engaged during this task, as we would expect, because they're making decisions, but it's no different between the two groups. Our hypothesis was, going back to Tim's original paper, was that the dorsal striatum, this more habit-related circuitry, would be more active for the patients in association with choice, and that was what we found in our first study. Here it is again, dorsal striatum more than ventral striatum for the patients and not for the controls. Well, that tells us about anorexia nervosa versus healthy controls, but there's a lot going on in anorexia nervosa. First of all, they're underweight, so that might be a big difference from healthy controls, especially in their brains. Second of all, they're doing something different in the behavior. They're restricting. So what we did in the next project was look across 4 different groups. Again, this was a new group of healthy controls and a new group of patients with anorexia nervosa. But we also looked at some sort of intermediate phenotypes, one being individuals who are healthy but had been on a diet and had lost some weight. So they were definitely restricting their eating. And a group of individuals who have, we called it subthreshold anorexia, it's sort of a misnomer, but they had the same amount of restrictive eating, but they were not underweight. And what you're seeing on the left in the behavior and the task is that both patient groups were significantly less likely to choose the high-fat food over the reference item. What you're looking at on the right are how the rating scales relate to their choice. So in the lighter bar is how their healthiness ratings relate to what they choose, and in the darker bar is how their tastiness ratings relate to what they choose. And you can see that for healthy individuals, and this has been well established in all of the cognitive neuroscience literature, for healthy individuals, they pick what they like. Tastiness is the main driver of what they want to eat. For the patient groups, for both patient groups, it was really healthiness plays a much more prominent role in what they choose. And interestingly, in the behavior, there's a clear split between the healthy groups and the patient groups. In the brain, it turned out to be a little bit different. So in the brain, we saw that, again, the main finding was that the caudate was engaged for the patients with anorexia nervosa much more so than for the healthy controls, and for the intermediate groups, that was not so clear. On the other hand, we do continue to see that there's a relationship, a correlation between engagement of the anterior caudate and the proportion of high-fat choices. So on the x-axis, high-fat choices, on the y-axis, caudate, and also in the meal. So that tells us about the severity. So that gives us an indication that the dorsal striatum is more likely to be engaged the more severe the restriction, the more severe the pathology. But the other part of the hypothesis was that it was about duration, and that as the behavior continues, it becomes more habitual. So the question was, how do we probe that part? And for that, we turned to teens. So the next part is going to be talking about a really wonderful project we got to do in collaboration with Jonathan Posner, who's now the Vice Chair of Research at Duke. And I want to do a little sidebar for trainees. For anyone who's interested in research, I would say that there are 2 phases of great joy in a research career. One is when you are sitting down with a new collaborator to think about an idea and really just try to figure out how can we test this? What's our question? What's the best way to put it together? It was just tremendously fun to have a collaborator with a different perspective. So Jonathan is a pediatric imager and a child and adolescent psychiatrist who could bring to this question everything that he knew about development and imaging, and we could figure out how are we going to test this thing. The next moment of joy is when the data come in. So we put this grant together about 5 or 6 years ago, And what we proposed was, as would be predicted by the original hypothesis, that the brain circuits early on in illness in teens might be, that food choice might be more related to the reward circuits or the goal-directed circuits for the early on in illness, and that over time it shifts to later, to the other dorsal circuitry. So we hypothesized that amongst teens, maybe there's more ventral reward circuitry involved. And then if we follow them over 2 years, maybe over that time, the dorsal striatum will kick in a little bit more. We also were able to capitalize on the reality that teens do better than adults, so that if we take this population of kids with anorexia nervosa, we could predict that about half of them will be well in a couple of years. So we would also be able to look at whether the baseline dorsal activation predicts persistent illness versus remission. And we are now done with the enrollment in this project, and we're starting to harvest the data. We still have another year or so to go before we can talk about what predicts longer-term course, but it's really just tremendously exciting to see what we've found. So none of this is published. All of this is us starting to dig into what we've learned about teens, and it's kind of the beginning of the next phase of mechanism. So we enrolled 91 kids with anorexia and 43 healthy teens. We looked at both the food choice task, which was what we're going to talk about today, and all of these analyses are led by Caitlin Lloyd, who is a T32 fellow with us. And then we also have resting state data, which we haven't looked, which I'm not showing you today, which are being analyzed by Alexandra Muratore, who is, as of tomorrow, a KORD and an assistant professor in our group. And here's who we've got. Okay, so this slide is ridiculously busy, and Tim is very disappointed in me for showing you this slide at all, but I can't help it because I just find it so exciting to see how much we have potential to learn from the work we've done. So what I will draw your attention to is just that these participants were all about 15 years old, which is about the mean age of onset of anorexia. And that we did, if you look over at the patient characteristics, we actually did capture them in the beginning of illness. So 80% were within the first year of illness, and 90% were within the first year and a half of illness. As a sidebar, looking at the demographics, I don't know how to do this, down at the bottom, I don't have any comment about it, but it is notable that the epidemiology here differed from what you would see in published reports, where we had only about a little more than 50% were white. I think that's interesting and probably is worth some thought. Here's what we did in the study. Basically, it's a day of procedures where we assess a whole bunch of things. Then in the afternoon, they do the food choice task in the scanner, and then at night, they did the laboratory meal for dinner. Getting back to the duration of illness, it is an important part of the hypothesis here that we're looking at the establishment of behavior and how that relates to what's going on in the brain. So the problem is that duration of illness is a very vague concept, very noisy concept. Who knows exactly when an illness started? And certainly the reports about it are pretty murky. So Lisa Ranzenhofer, who's an assistant professor in our group who studies teens across the spectrum of eating disorders, figured out an age of onset interview where she was able to capture in fine-grained detail when behaviors began, and she asked both the parent and the kid. And we are happy to report that we did, that the mean duration in this group was about 6 months. But what she also learned is that the dieting had been going on for about a year and a half before the illness was diagnosed, and also that this was the only behavior that really differed between between parent and child, where the kids would report it about 6 months, having started 6 months before the parents. So what did we find? Okay, so here's this task again. Again, same thing in the rating scales that we've seen with adults pretty much. And again, the teens are restricting their selection of high-fat foods. This is just letting you know that the task works in teens as well, who are already manifesting this behavior. Looking at the influence on choice in teens, you again see it's sort of presented the other way, so it's a little bit harder to follow, but you can see that for both groups, tastiness influences choice, but healthiness is a significant influence only for the patient group. And that's related, presumably, to the taste and healthiness ratings being very highly correlated in the patient group. This is what we've seen in adults, and I'm highlighting it only because it's a little bit depressing from a clinical perspective that whatever it is that's guiding decision-making around food has already happened even that early on in the illness. So then we wanted to know what's going on in the brain. So for this, our hypotheses were that we were going to focus on the nucleus accumbens and the anterior caudate as our regions of interest. So that's what we have done so far, is really take a look at whether there's a difference between the reward system and the habit system in what's guiding food choice. And if you look at the reward system, remember our hypothesis was that it would be much more active in the teens with illness, and that is not the case. They look quite the same. And then that to look at how that compares with what's going on in the caudate, in the dorsal striatum, you kind of need to know what's going on for healthy teens. So you can see that there's actually, for healthy kids, they're actually using ventral striatum a little bit more guiding choice than they are the anterior caudate. And that is not the case for the patients with anorexia nervosa. So there's no difference between the groups in any of these, but there is this sort of intriguing finding that the expected ventral engagement is not quite the same in the patient group. More importantly, we see, as we have seen with adults, that there is a correlation between the behavior, the selection of the high-fat food on the y-axis, and the engagement of the caudate, in that the patients with anorexia nervosa who have more caudate activation are more restrictive. That's the same thing we've seen before. This relationship is not present for the nucleus accumbens. Okay, that gets us to the end of what we've learned about mechanism for now. And what I hope I've demonstrated is that this pathological dietary restriction, the pathological tendency to limit intake of high-fat foods, is pretty much associated with this dorsal striatal activation in the anterior caudate. What may or may not have been obvious, but is something that we keep pondering, is that there's a lot of similarities between the teens and adults, and then also some slightly different patterns that are intriguing and will be the subject of what we get to figure out over the next 2 years as we finish data collection. So far, we have about maybe 75% of the sample, and we are seeing the expected difference where about half the kids are well and about half the kids are dealing with persistent illness. So we anticipate that we will actually be able to answer our original questions. Okay, now we can talk about treatment. So how have we used all this to think about what we should be doing for treatment? Well, we've got basically 2 different types of targets to develop treatments for. There's the neural target of the dorsal striatum, and then there's the behavioral target of habits. So first, to the neural target, this is Alex and Caitlin, again, demonstrating transcranial magnetic stimulation. So Alex has led a project looking at whether you can use neuromodulation to change food choice. And so this is the transcranial, here it is. The TMS coil is applied to the dorsolateral prefrontal cortex, which is not a section I've described yet in any of what I showed you, but of course the TMS coil can only go so far, so you have to find the region that's connected to the more, to the deeper structure. So what she's done is use this magnetic coil to modulate the activity of the DLPFC with the expectation that that is having a bigger effect on the whole circuit. And what she did was did it while patients were doing the food choice task. So she had a real coil and a sham coil, and she looked at whether that could change behavior, and it did. So applying the single session of TMS to the DLPFC was associated with an increase in choice of high-fat foods as compared with the sham condition for these patients. These were inpatients on the unit here. And you can see from the individuals that it was a pretty consistent finding. TMS has also been used in a full clinical trial in the UK, where they gave a full course of TMS to the left DLPFC, and they also looked at a food choice metric. This is a slightly different metric. It has to do with engagement of self-control, and I'm not going to get into it because it takes too long. But basically, you can see that there was here a difference as well, where the ones who got the sham treatment didn't have a change in their choice behavior, and the ones who got real TMS did. So this just suggests that there's at least something promising here in using TMS to maybe impact actual eating behavior. Okay, to the behavioral approaches. So within behavior, we have kind of two targets that would be, that fall out of the habit model. So if we're thinking about habitual behavior, there's the cues for the behavior that you can try to change, and there's the strength, the habit strength that we talked about before. So those became the targets for our intervention development. And this was led by Debbie Glassifer here, who helped develop the behavioral interventions. She's in the top picture, with our collaborators from the Midwest, who helped us develop a brief intervention for the inpatient unit. So these were patients getting regular old treatment on our unit for anorexia nervosa. And while they were there, they got 12 sessions of either a habit-busting approach, which we call REACH, or a supportive psychotherapy. And the patients who got the habit-busting treatment did, in fact, have a decrease in their habit strength score over those during the intervention. And this, to me, is the sort of eye-opening finding. They ate more. So this was about 10 people in each group, 11 people in each group, something like that. And they actually showed something of an increase in their intake in that laboratory meal, which is startling because if you remember back at the beginning, I showed you that even with 4 months of inpatient treatment or 2 months of inpatient treatment, we couldn't get eating behavior to change in the lab. So this is quite promising and leads us to what we're doing now, which is a developmental study looking at trying to optimize this REACH package for relapse prevention. So now REACH, I don't know if anybody noticed, but the acronym changed. Now it stands for Relapse Prevention and Changing Habits in Anorexia Nervosa. And this is a developmental study where we're trying to take all the tools that we've been playing around with for how to change habits and get them into a package of treatment that can help patients stay well after they leave the hospital. So we provide 6 months of care. It's all telehealth visits. And the intervention is supported by some extra support on our first mobile platform, which I'll show you briefly. The study design is a kind of fancy clinical trial design called multi-phase optimization strategy, and basically that allows us to figure out which of the components of treatment are active in helping the patients and put together at the end of the trial the best package to test in a future RCT. The reason we're focused, I'm going to back up for a second to explain why we're doing this as a relapse prevention treatment and remind you that about half of patients with anorexia nervosa relapse after they leave the hospital in the adults. This is the original Prozac versus placebo study that was done here. And so half of these participants were on our inpatient unit here. And even here, where we do it best, about half of them relapsed within the first 6 months. Tim recently took a closer look at these relapse data and found that, so what you're looking at on the y-axis is the likelihood of relapsing in the next 60 days, and you can see that the probability of relapse goes up pretty quickly and then kind of settles out. The treatment that we're doing captures up to that arrow, so we're hoping to capture this kind of critical vulnerable time period. And now this is the study, the crazy design. So the overall idea, the conceptual model here is that this is a treatment package that targets habitual control of maladaptive behavior. To do that, we give people a whole bunch of different treatment components that each of which has some evidence for it. So in the dark blue, the core components, everybody gets psychoeducation, weight monitoring, the things that are the mainstay of treatment for anorexia nervosa. And then in the green boxes are the 5 different components that we are investigating in different ways. Each approach has some empirical support, so there is no placebo, there is no inactive control arm, but what we can figure out is which of these are active in preventing relapse and helping people maintain weight. And importantly, each component also has a proximal target so that we can measure whether this intervention hits its target of decreasing habit strength, for example, and whether that's related to maintenance. And we can do all this very efficiently in a relatively small sample size because of the ways that this fancy clinical trial design works. So the treatment, again, developed by Debbie and Evelyn, the treatment focuses very much on this main thing, interrupting habits, and does that by identifying cues and trying to find rather than helping people think about why they should change their behavior or what the outcome might be if they do something differently, it really has people focus in a very granular way on what were the cues for the behavior, what led to it all to happen. So the timeline kind of goes in reverse in thinking about how to help people. And everybody focuses on behavior in this way, and everybody focuses on learning about their behavior and trying to find new ways, new paths that they could take, and seeing if there's rewards, any type of rewards associated with these new paths. And the difference between the two components, what we're testing is is it most helpful to patients if you sit and eat with them? Is that the best way to figure out what their habits are? Or can you talk about eating and come up with experiments that they can do in between sessions? Along the way, these are people, so their behaviors also come with thoughts and a whole lot of other pieces of the illness. So we don't ignore those in this treatment. We approach those with different ways of addressing unhelpful thoughts, either by challenging them or by learning how to accept them to some extent. So this kind of illustrates how the whole treatment works. But it isn't just the sessions. This is our first effort at creating something into kind of digital health and how we can use digital health to augment the treatment. This is our landing page where you can learn about the study and participants can log in. These are our fabulous study therapists, Michelle and Brooke, who are really doing the lion's share of the treatment. In addition to their sessions with their therapists, the participants have access to a whole bunch of information online, and this includes a whole bunch of a range of materials that are video and reading and also interactive, where they can do their between session work. Okay, so what I've told you so far is the main point, the thing that is most important to me about all of this, is to really demonstrate that anorexia nervosa is a neurobiological illness. That may be not needing to be said here in this room. It may be that in the Department of Psychiatry that goes without saying, but it really doesn't go without saying. It really, as much as it was a major effort for the field to establish that eating behavior was the central phenomenon, which occurred again many decades ago, it is now a shift in the field to really advance understanding of what is going on neurobiologically. And we are kind of launching a lot of that research across the field. The work we're doing here really focuses on restrictive eating as the central behavioral mechanism and the place where we're trying to target our treatment. And we are currently particularly focused on the dorsal striatum because that's where this story began. But as much as we are focused there, a lot of interesting questions come up along the way. So we see this very strong correlation between the anterior caudate and the behavior of interest. But how? Why? What is that doing? How exactly does that lead to the problems that we see in anorexia nervosa? That remains to be seen. So now, if you will indulge me in 3 more slides showing you what we're doing next to try to keep this question going. There are a bunch of things coming down the pike for studying mechanism. The first is, again, the opportunity to collaborate with child psychiatry and Jonathan, in addition to several collaborators here, Elizabeth Sublette, Guillermo Jorga, and Janet, to really understand in these teens what happens with starvation. So I showed you that whatever it is that happens early. And maybe it's there before the illness starts, but it certainly seems like there's something that happens with starvation itself that affects the brain in some important way. So we are going to now be able to look at whether there are specific nutritional effects from amino acids and fatty acids that affect dopamine synthesis and the developing dopamine system, which in teens is very actively developing, and maybe there's some kind of confluence of the starvation effect and the development that is important for the long-term course. And then Blair Uniacke, who's our unit chief here, is also, she's taken the first steps toward this and demonstrated that there looks to be less dopamine in the brains using these neuromelanin scans, which she's done in collaboration with Guillermo, and I don't know if people were here last week, but last week's Grand Rounds was about greater levels of dopamine, and so here in these neuromelanin scans, we're seeing a decrease in dopamine, and she's going to be continuing to look at that as we go. And then we also are trying to understand how habits and goals relate to longer-term course. So we are working with Karin again, now at University of Amsterdam, and that's Nathaniel Daw at Princeton, to really dig into using computational methods. How does this happen? How does behavior get guided by one story or another? What makes it habit? What makes it goal-directed? In what ways? So we're going to be doing a whole battery of tasks that will discriminate between habit mechanisms and goal-directed mechanisms and evaluate whether these relate to habits to persistent illness and goal-directed to remission. And we can also do that by capitalizing on our ongoing treatment study. And Alex is going to be looking in collaboration with Kate Fitzgerald, who brings expertise in thinking about neuropredictors and what kind of predicts the outcome from treatment. We'll be able to look at whether those dorsal circuits are related to people who do poorly with the treatment, or whether cognitive control or other aspects of neural architecture relate to success with our REACH treatment. Other new directions for treatment development, Alex is going to continue to look at TMS and really try to figure out what are the best targets for trying to change behavior. Taking us in a slightly different direction, but still related to kind of shaking things up in the brain and seeing if we can get people to do things a different way. Evelyn, in collaboration with David Hellerstein, is going to be one of the sites for this phase 2 clinical trial of psilocybin for weight restoration for anorexia nervosa. And with that, I want to thank all of these wonderful people who did all of this work. Thank you.